Good afternoon, ladies and gentlemen. Thank you so very much for being here again today. We have an amazing program, although we always have amazing programs. So it's great that you're here today. I want to give you a little bit of a history of how this came about. Many years ago, we started a regular healthcare luncheon, years and years ago. And it was to enlighten our donors and our friends about the things that the foundation was doing, whether it was technology that we were supporting or a new physician that was coming into town and so forth. But thanks to Margaret Wise and Ann Charters 4 years ago, they started Women and Medicine. Not Women in Medicine, Women and Medicine. And since that time, we have been able to enlighten our community as to the importance of what healthcare means to all of us. And women, as you know, are the predominant individuals that carry over the healthcare issues and talk about them and take care of their families. So we are delighted that you're here. We have an amazing panel of cancer specialists and reconstruction specialists that are going to set Sarasota on the map. They already have put Sarasota on the map, and we are delighted that they were here to share with you a Q&A session and an opportunity to learn about the cancer programs here at Sarasota Memorial and in this beautiful community where we all need to be treated and our friends need to be treated. So thank you again for coming. I wanted to mention a couple of people that are important to us in this community that have been beside us, that work with us, that are trustees. Rich Garrity, Bill Chapman, Kirk Volker, Dr. Volker, who is also one of our past speakers, Jim Seipert, Deb Kavanaugh, who is a trustee as well. Also, we have some representatives from Sarasota Memorial Healthcare System, Dr. Marguerite Malone, our immediate past chair of the Hospital Public Board. Susan Brennan is one of our board members. And then, of course, we have some wonderful staff people who represent Sarasota Memorial Healthcare System that are here. Thank you for coming. Jan Mock, Pam Ramhofer, Carol Ann Kalish, Pam Beitlich, Lori Lang, our new Chief Operating Officer, Dr. Wilhelmina Weiss, and I'm not going to get this right, but I'm going to say Reinwald. And, of course, Karen Hammond, who is not a staff member of the hospital, but she has offered to let them sit at their table, and Karen has been a tremendous supporter of what we do. The two people that really need a lot of recognition this year is our trustee, Deb Kavanaugh, as well as Charlie Ann Seipert, the chairs. These women, along with the staff of the foundation, have worked tirelessly to bring forth for you the opportunity to hear some of the most advanced oncology work that is being done right here in Sarasota. And let me guarantee you, having come from another cancer center where I spent 7 years and started their foundation, you do not need to leave Sarasota for your cancer care. Let me make that very clear. You do not need to leave Sarasota for your cancer care. It is here. And we are planning to build a freestanding cancer center in the very near future just for you. We have a lot of people that have been supportive of this program. Unfortunately, it touches all of us. I will say my mother passed away of cancer, so it does run in my family as well. So it's very near and dear to my heart. But at this point, I would like to invite Deb Kavanaugh and Charlie Ann Seipert to come up and lead this group to the program. If you would join us, thank you.
Well, thank you all for coming. We really appreciate it. Look around the room. We apologize for being so squished in here. We are sold out. So we promise you next year we will move to a larger venue so that you can have a little bit more elbow room as you eat your lunch. But we're very pleased to have you here. I'd like to introduce Liz Dukes. Liz is the Chief Strategy Officer of Synovus Bank, and Synovus is our premier sponsor. We're very grateful to Synovus because they stepped up to be our premier sponsor, not just this year, but also for next year. So thank you so much, Liz.
So on behalf of Heidi Colgate-Tamlin, Jen Russ, Jennifer Stubbe, and the entire awesome Synovus team sitting over here at tables 1 and 2, I believe, we are so proud to be your premier sponsor of the Women in Medicine Luncheon. Thank you for your attendance today, and especially for your support of the Sarasota Memorial Healthcare Foundation. I'm honored to be part of a company that has a passion for people, for making lives and making communities better, and I'm equally honored to be here today among this room full of passionate, talented individuals that have the same priorities. For more than 120 years, our Synovus team has remained committed to building relationships and not just bank accounts. This kind of personal banking involves far more than taking deposits and providing loans. It means being here in one place for the long term, and it means engaging at a much deeper level than just doing business or earning the right to the next transaction. It means connecting with people and helping people connect so that individuals and businesses can fulfill their potential and thrive where they are. That's the best way that we know to help ensure the growth of communities where we operate and therefore the long-term health of our organization. We're not the oldest and we're not the largest bank in Sarasota, but I think you'd be hard-pressed to find anyone with deeper roots in the community than Jennifer Stubbe or a stronger commitment than Jen Russ. Synovus people and their commitment to communities and customers have been recognized several times in the past few months, and if you will just allow me a second to brag, just a little bit. In June, American Banker and the Reputation Institute named Synovus one of the most reputable banks in the country. Synovus was one of 3 ranked in the top 10 among both customers and non-customers. And in September, Consumer Reports named Synovus one of the best banks for customer service. And in January, we received the 2nd highest score of all banks in Consumer Reports for the Best Banks for You feature. And we're obviously proud of these accolades, but they're not the goal. They're not the reason we're in business. They are instead a result of the goal, which is to engage with people, understand their purpose, and to provide support for the community that all of us are building together. So thank you for all you do for support of the Sarasota Memorial Healthcare Foundation, and thank you very much for the opportunity to be here today.
Thank you. Now it is my great honor to introduce Karen Hammond, who is Chief of Staff at Sarasota Memorial Hospital. Karen will bring us an update on some exciting events at Sarasota Memorial.
Well, usually I'm really nervous to do these sort of things, but I can tell you that to stand up here as a Chief of Staff of Sarasota Memorial Hospital, I'm so proud and excited to get a chance to brag to all of you about how amazing our hospital is. I think I speak for the entire 800-plus medical staff when I say that we all come to work every day with a smile on our face, and we really are very lucky where we get to work, who we get to work with, and who we get to work for. So thank you very much on behalf of the medical staff at Sarasota Memorial Hospital. So we've got some exciting things going on. In November, we celebrated our 90th birthday, and that celebration was attended by the mayor, some other local dignitaries, but I think the best part of it was seeing the volunteers and the employees who'd been there 30, 40, even 50 years come and get recognized, and that tells you something when you can have such loyal volunteers and employees. It was a wonderful celebration. On May 1st, the state designated Sarasota Memorial Hospital a provisional level 2 trauma center, as you all know. We have treated 1,280 trauma patients so far. We have 8 trauma surgeons, a trauma orthopedist, and several other critically necessary specialties. currently there to take care of the patients. And in the next few months, the state will come and finish our approval process, and we will be a fully accredited trauma program. That provisional banner can come off. Something very near and dear to my heart, we have launched an internal medicine residency program combined with FSU and SMH. We were lucky enough to hire Dr. Wilhelmina Visa-Romech, who is here today, and thanks to her, we flew through our site visit yesterday, and we were told that we have set the bar at a highest level they've seen for a new application for a residency program. So we won't hear back the final word until April, but we're all very optimistic. We will be training 13 internal medicine doctors a year, and it's a 3-year program. So after 3 years, we'll have 39 residents at the hospital. That leads me to talk about something else that the hospital is doing. We are building a primary care clinic in Newtown, which will be the resident-run clinic. That will be extending healthcare to a part of town that really has significant disparities. The city's been very involved, the mayor's very excited, and we will be bringing primary care to Newtown with our residency program. Our rehabilitation center is being built currently. It will be all private rooms. It's on the south side of the hospital campus. There will be a mobility garden to help patients get back on their feet, and we anticipate it will be completed at the end of 2016. And we have an urgent care on St. Armand's that is slated to open in the fall of 2016 as well. So as you can see, we're continuing to grow and build and support this community as best we can. Thank you very much.
Thank you, Dr. Hammond. All right, here comes the quiz part. Is everybody paying attention? How many people here, I'd like a show of hands, raise your hand if you have significant responsibility for healthcare decisions related to yourself and family members. Anyone who has that responsibility. Look around the room. That's why the Healthcare Foundation is committed to providing this kind of educational program for us. We sold out this event, had a waiting list of people wanting to attend. From my own family, my sister is here, my niece, and my soon-to-be daughter-in-law. So we have multiple generations. Anyway, remember next year, buy your tickets early. We're here today to help everyone gain information about critical health concerns and also provide information about the resources available in our own community to address your healthcare challenges and concerns. We're having a discussion with 3 different physicians here. So each of them will give a short presentation, and then we'll go ahead and have question and answer period. So on your tables, there are questions cards, and feel free to write your questions on that. We'll be collecting those and then having a question and answer session. At your place at your table, please also notice the Sarasota Memorial Hospital Healthcare Foundation zip drive. Will someone hold one of those up for me? That is a zip drive, and that has the slides from each physician's presentation. You want to go ahead and take those home with you. That also has room for you to use as a zip drive, so you can keep that and use it for your own purposes in addition. This is the 4th year that I've chaired this wonderful event. In planning for this, we realized it would be beneficial to create a Women's Leadership Council to spearhead this event every year. Then we realized that we shouldn't just stop there. The Women's Leadership Council members can serve as ongoing leaders committed to learning about critical healthcare issues, as well as learning about healthcare resources in our own community, and then serving as ambassadors to communicate this information throughout the community. For example, next month, the Women's Leadership Council of Sarasota Memorial Healthcare Foundation will be attending the groundbreaking program for the new Sarasota Memorial Hospital Rehabilitation Pavilion that Dr. Hammond described. For those of you who would like to get more involved in the program, please let us know. We'd be glad to include you, and we think this will be a very dynamic group going forward. I'd like to now introduce my co-chair, Charlie Ann Seifert.
Good job. Well, I feel compelled to first say, I don't usually have a pink streak, but Dr. Schulman, I kind of like it, and Jim, I think I'm going to keep it. I kind of like it. I want to go back to what Alex Quarles said, that you don't need to leave Sarasota if you're looking for good health care. I have read many times, and I've been told many times, when you're faced with, you or a family member are faced with a cancer diagnosis, you need to be, the best outcomes go to those patients who reside in a community who have in its war chest in the battle against cancer three things: a caring, supportive community that's informed and educated and that inspires its institutions to be the best it can be. Check. Look around the room. All of you are supportive and have been over the years of the Sarasota Memorial Healthcare Foundation and this institution. Number two, a top-notch, world-class team of medical doctors and other healthcare providers. Check. And number three, the latest in technology, the most advanced and successful cancer care treatment plans that exist today. Check. And after today's presentations, I know you're all going to agree with me that we reside in one of the best communities, not only in the state, but in the nation and perhaps globally for healthcare. I'm very honored now to present to you our speakers. And I think what I'm going to do is Dr. Meredith, Dr. Schulman, Dr. Fiorica, if you would all come and join me on stage and have a seat in these wonderfully comfortable chairs. Each doctor will make a about 12-minute presentation, and I've been elected to be the Doberman pincher to get you off the stage if you go over your time limit. And then following their three presentations, we will have questions. And the order of the presentations will be Dr. Meredith, Dr. Fiorica, and then my pink pal, Dr. Schulman. I have nicknamed each of our speakers, and I call Dr. Ken Meredith our Super Bowl winner. You don't need to watch the Super Bowl on Sunday because we have the winner right here. Our healthcare institution really was parlayed in the forefront of healthcare when he came to our institution to lead the gastrointestinal surgical oncology program. He has pioneered robotic and minimally invasive surgeries, and I am so proud to tell you that he has performed more robotic esophageal surgeries than any other doctor in the entire world. And so why is that important? Because you couple that with his expertise and skill, and that translates to better positive outcomes. He has authored over 35 articles that have been received by institutions around the world, and I think after you hear his 12-minute remarks, you will agree that he is the Super Bowl winner. Dr. Ken Meredith.
Thank you. Well, thank you. This is an honor to have been invited to give a talk in such a close community, and I'm very honored to be here and want to extend a personal thanks to the foundation. I couldn't do what I do without their continued support, so thank you. I'm going to talk about gastrointestinal surgery, I hope my time hasn't started yet, because I have to preface it by saying I do courses for robotic GI surgeons for surgeons all over the world, and the lecture I'm about to give is usually an 8-hour lecture. So I have 12 minutes to give an 8-hour lecture. So here we go. This is what I do. This is the different operations that I do. So let's see if we can figure out which one of these. Oh, we have green today. Okay, so esophageal cancer, as was previously mentioned, I pioneered robotic esophageal surgery. Unfortunately, when I started doing robotic surgery, there wasn't anyone really doing intrathoracic anastomosis or a connection between the stomach and the esophagus in the chest. Most of the time, patients got their entire esophagus taken out, and in doing it, predisposed them for high risks after surgery. I'm going to review some of the minimally invasive data. I'm going to talk about some of my data, again, in 12 minutes. If we have time, I'll talk a little bit about pancreatic surgery, because that's another one of my passions. Both of these malignancies are highly lethal malignancies, and in the past, you look at esophageal surgery, a 2-foot incision on the abdomen, a 2-foot incision on the chest, and then now we've extended that to decrease it to a 2 to 3 inch incision. That's it. With improved oncologic or cancer-related outcomes, and patients get out of the hospital sooner, smaller incisions, and they get the adjuvant therapies a lot quicker. Pancreatic surgery, also highly lethal. There's a very technical operation I do that there's a handful of us in the country that do that operation, really in the world, that do it to a high volume. We take out the bottom part of the stomach, the head of the pancreas, the bile duct, the gallbladder, the duodenum, and then we have to reconstruct it, and we do it through an incision that's about that big as opposed to an incision that's that big. So that operation is more technical. I have some videos, so if there's anyone squeamish in the audience, I'm just going to warn you now. If we have time, I'll show you some of the videos. All right, let's go. Here comes the boring stuff. So esophageal cancer is about the 8th most common malignancy in the world. We have squamous cancer and adenocarcinoma. Squamous cancer really is more common in the smokers. Adenocarcinoma is more common in the Western world, mostly because of reflux, our diet, and transformation of the squamous esophageal mucosa to metaplastic or metaplasia columnar. In the United States, it's about 1% of all malignancies, but it's 8% of all GI malignancies. This statistic is really going to alarm you. In 2015, we had almost 17,000 new esophageal cases. We had 16,000 deaths. Now, these are all comers. Unfortunately, we've had a 20% increase in the diagnoses of esophageal cancer. And look at if you can see that, over a 20% increase in esophageal cancer-related deaths. I will tell you there is hope. You compare the overall survival to the 1970s, and we've more than tripled the overall survival for esophageal cancer. Why? Our surgery is better, and multidisciplinary therapy is better. So this is a male-driven disease. It's the number 7th leading cause of cancer-related deaths in males. As you can see, in females, it doesn't reach the top 10, but it is the 13th most common cause of cancer-related death in males. So women can get esophageal cancer. About 20% of my practice is female. Treatment for esophageal cancer. I'm a surgeon. I operate on foregut malignancies. But not all esophageal cancers need a big operation. If you have an early stage esophageal cancer, a T1A tumor, you can get an operation that's done by the endoscopic oncologists. Yes, I call them endoscopic oncologists. They're gastroenterologists that have specialized training. They can do everything from the inside out. And I've built a multidisciplinary team with the gastroenterologists here in town, specifically Steve Casera and Dr. Kazanchi. Those guys can do these advanced procedures. So for very early stage esophageal cancer, you may not even need to see me. This is the type of esophagectomies done across the country. We have transthoracic, which is a big incision on the belly, big incision on the chest, the reconstructions in the chest. Transhiatal is a very morbid operation. We try to avoid that, but still about 30% of operations done will entail that. Basically, for lack of better terms, you take your hand and you rip the esophagus out through the mediastinum and you come out of the left neck. It's a very blunt operation. You can imagine that has a very high complication rate. And then there's a 3-incision approach. And then, unfortunately, laparoscopic and robotic is very minimal in the actual number of operations done across the country. Why? Well, we all believe in the mission for decreasing patients' postoperative pain, improving their outcomes, but this isn't a new phenomenon. This was actually pioneered in the 1990s. And if you look at this statistic, this is the number of publications of minimally invasive surgery from the institution to now. You look at from 2010 or 2006 to about 2010, 150 publications. That should translate into more operations done minimally invasive. If you look here, though, that's actually not the case. Only 30% of the esophagectomies done in our country are done minimally invasive. That's despite prospective randomized data that shows there's a benefit for minimally invasive surgery. So the reason that surgeons don't do minimally invasive surgery, well, it takes a little bit longer. I'll say that with a little trepidation. That's true and not true. It depends on where you're at in your learning curve. Surgeon burnout, they may start to do an operation and realize they can just do it a lot quicker, faster. Yeah, it's not necessarily the best for the patient, and there's always costs associated with increased technology, and then all the different technique kind of precludes the recommendation of an approach. So a lot of the issues that surgeons that do open surgery have with minimally invasive surgery is, well, there's a lot of potential complications. Yes, you can avoid those by having a mentor that gets you through the process. The best thing for the patients is what we should do, and that is what we should all be driving. So it takes about 17 cases for just minimally invasive surgery to get an improved outcomes, but your learning curve isn't just about being able to do the operation, it's also about being able to see a difference in patient outcomes. It takes 35 cases to get your complication rate lower. If you figure that most surgeons are low volume surgeons, they don't do but maybe 5 esophagectomies a year. That's 7 years before they would get proficient in doing a minimally invasive operation. That's why these complex cancers should really be regionalized to high volume surgeons. Otherwise, they're never going to get past their learning curve. So we've come a long way from operating with chopsticks, which is basically the minimally invasive way to do things. We now have the robotic system. And the robotic system, when it first came out, if you look in the early 1990s, it was basically a very clunky system, did not have a 3-dimensional camera, basically only had an arm for a camera and then 2 other working arms, and they had to literally retrofit that robot for another arm so it would be more usable. And then we developed the SI, or not we, but the company developed the S system, which came with a 3-dimensional camera, and then we get all the bells and whistles. And now, at Sarasota Memorial, we have the latest technology with which only a handful of places in the country have this system. Why is this so important for what I do? This is important because it allows me to operate in multiple quadrants at the same time. I no longer have to make multiple incisions. I can do a single dock technique. The other huge benefit is it has a targeting system seen on the bottom right here, and it's a smaller, more compact system. This is the old clunky system in the middle. Yes, we still have that. I shouldn't call it old clunky. I actually did a case on this, an esophagectomy on this last week. But preferentially, I like to do with the newer system. So why do I like robotic surgery? You know, I get into debates all the time with my minimally invasive surgical colleagues, and the reason I do robotic surgery is because it makes me a better surgeon. I have yet to see a minimally invasive surgeon be able to operate with 3 hands. I can't operate with 3 hands as an open surgeon. I'm sorry, I just can't. But the robot has 3 arms, so I can control 3 arms at any given time. I have a 3-dimensional camera that I control the camera. A minimally invasive surgeon most of the time doesn't control the camera. There's a student, there's an assistant, there's someone else controlling the camera. They cannot do those things at the same time. The other difference is I have, as seen in this picture here, I have the ability to articulate my hands as opposed to just moving like chopsticks. So it allows more similar movements to open surgery. So This is the number of robotic esophagectomies. When I started doing robotic esophageal surgery in 2008, I was almost laughed outside of Moffitt because they said, "You want to do what? You want to do an esophagectomy with the robot?" And I'm like, "Yes, I think it's going to be the new wave of the future. I think it's going to be better than traditional minimal invasive surgery." And now I have grown the largest volume of esophageal surgery on the planet. You look, this is when I started before 2008. Now we have over 500 esophagectomies done worldwide. When I started, there was maybe 20 done in the entire world, and about 19 of those were mine. So this is my technique, and I'm going to go through these because I don't know where we're at with time here. But this is the incisions that I actually use for my patients. Oftentimes, instead of an additional incision there on the bottom right, we'll put a feeding tube in there. 50% of the time, I won't put a feeding tube in now. Why? It's a common myth that patients that have esophagectomy won't be able to eat. 90+% of my patients are discharged from the hospital eating a solid diet. Again, a solid diet. And we don't take the entire esophagus out like they do with other techniques. Sometimes you need to, depending on the location of the tumor. This is a 3-port technique that I actually wrote and published on a few years ago, rather than the 6-port technique that's pioneered by Jim Lukatich. This is 3 robotic ports, and you see on the right, that's my actual incision. That's the biggest incision you have on the chest. Instead of that, with the whole rib taken out, which I didn't mention before, with the chest operation, you get a whole rib taken out. No rib taken out, small incision. So this is the targeting system. If we can start the video. Maybe I can start it. There it goes. So you can see, I'll just briefly show this. This is actually a video of a patient that I did recently, and this is a targeting system. You can actually maneuver the robot. You attach one of the robot arms, you press the targeting button, and it automatically configures the robot to the best orientation so there's no conflict of the arms. The other difference between this and the SI system is because the arms are smaller, if we can start that video, you can actually manually maneuver the arms with a button so that you can change the angle. So there's really, even on a very small patient, there's no conflict with the arms. And now, okay, so this is the graphic stuff, so you can close your eyes. This is an esophagectomy. This is the different arms that you can use robotically. Here, this is the esophagus lifted up in the air. We're actually putting a Penrose for retraction around the esophagus. This is a celiac lymphadenectomy. We can get all of the lymph nodes. That bottom part that you're seeing here, that's actually the pancreas. So we take the lymph nodes all the way down to the head of the pancreas. This is where I think a lot of surgeons that do esophageal surgery actually don't get adequate nodal harvest because they don't dissect far enough down. On here you can see the visualization. That's the aorta pumping. That is the largest vessel in the body, and that's pumping. That's how low we are on the blood vessels. If you look here, our operation time dropped from 514 minutes to 414 minutes. Because the sheer volume that I've done now, our actual OR time is about 380 minutes now. Complications. In our first 30 patients, really 29, we had 10 complications, or 34% complication rate. Believe it or not, that's actually very low. Open esophagectomy has about a 60% complication rate. But after our learning curve was done, 23% complication, and now we're down to 19%, which is the lowest. It's even lower than the minimally invasive data. This is the largest series that's about to be published of robotic esophageal surgery. This is actually my data, every bit of it. So if you look at the actual outcomes, we had no conversions to open, which is markedly different than the minimally invasive approach, which has a 10 to 20% conversion to open, zero conversion rate. We had our postoperative pneumonias early on was 10%, which is really low. Now 6% pneumonia. That's the #1 complication associated with esophagectomy. Most importantly, and this is the slide I want as a take-home message, this is our oncologic outcomes. Our lymph node harvest rate is 20 nodes. Now, most people don't know if that's good or bad. 80% of our patients get chemoradiation, and with chemoradiation you get a decrease in nodal harvest, and it's usually around 10 to 15. This is higher than the standard across the country. Because of our improved visualization, our ability to do a more thorough dissection, our R0 resection rate, not quite 100%, 99.4%. Again, one of the highest R0 resection rates that's going to be published. And our complication rate is very low. So I'm going to skip through all the pancreas because I have to show you some. I also do robotic pancreas. I have a very good robotic video. These are my data that's about to be published on robotic pancreas surgery. So in summary, minimally invasive techniques, it's the wave of the future. You may or may not be a candidate for a minimally invasive approach. I will tell you 99% of my esophagectomies are done minimally invasive, okay? If it can be done, I can do it. Pancreas is a little different. We can talk about that just because a lot of vessel involvement. Longer learning curves, but why should we do it? Because patients deserve it. Patients deserve a smaller incision if they're going to get the same or better oncologic outcomes. And surgeons need to do what's the best for their patients. So this is what we used to do to patients. And believe it or not, this on the right is actually a smaller incision. This is a mini thoracotomy. Mini thoracotomy that I used to do before I started doing minimally invasive surgery. And this is what we've exchanged it for. You can't even, and this is a patient I did here in Sarasota. You can't even see. He's 6 months out. You can't see any of his incisions. So again, thank you. I went over just a little bit. I apologize, but thank you.
I hope you saw the relationship there. We have a top-notch doctor who wants to bring to Sarasota the latest in technology. That costs money. That requires a community to support that. And we have Alex Quarles and her team raising the money, you giving the generous money, and we make it happen. So this is a beautiful thing. Our next doctor is very special to me because we hail from the same hometown in upstate New York, a small world. His brother is a pulmonologist in Lewiston, New York, a little town near Niagara Falls, and he treated my grandmother. Dr. Furarica really gave the Powerball winning ticket to Sarasota Memorial when he decided to come here in 2005. He spearheads the Women's Cancer Oncology Program, and in doing so, he's really changed. He's been a game changer. He has brought to Sarasota not only robotic surgery for women's cancers, but he has brought the access to genetic testing, and you spearhead our genetic testing program at the hospital. He has made it possible for our patients to have access to the most revolutionary, innovative, and personalized clinical research studies that ultimately bring the latest chemotherapies to patients here in our community. He has published over 175 articles that have been accepted both not only in the United States but worldwide. To demonstrate his rock star status, he is a most sought after speaker throughout the world, and he trains other physicians. He has created, in addition to his research, some teaching and instructional materials, including medical videos and textbook chapters. It is my honor and privilege to introduce to you James Furarica.
You're too kind, thank you. So I want to remind everyone that your credit card thumb drive has all the slides, so if you can't see them on the screens, and I'll try to read what's on the slides, it's all there in your thumb drive. This first picture was taken in the new courtyard at the hospital at Sarasota Memorial, and I know many of you contributed to that courtyard tower, and thank you very much for that. It's a beautiful state-of-the-art hospital tower, hospital wing, and thank you for doing that. What I'd like to do in a short period of time is sort of break this talk into 3 parts. And this whole luncheon is my focus is research, new frontiers. Dr. Meredith talked about technology with the robotics and surgical advancements. And Dr. Schulman's going to talk about body image. With the research part of it, I just want to focus specifically on what I do, female cancers. And as a brief anatomy class, you have up on the slide, you see we're going to talk a little bit about what I'm doing in breast cancer, the most common cancer in women. In 2015 statistics, you see there 231,000 cases last year. Uterine cancer, 54,000 cases. Ovarian cancer, 21,000 cases. Cervical cancer, 12,000. And then last on the list that we won't talk about is vulvar cancers or genital cancers. But these are our top cancers, and the anatomy sort of shows you what we're talking about is from a schema from where the ovaries are situated relative to the uterus and the cervix. And I'm going to bring that out because as we talk about screening studies, that picture is going to become important of how the relationship between the uterus, the tubes, fallopian tubes next to them, and the uterus and the entrance to the vagina. So if we talk about research and cancer research, you know, cancer research is an ongoing process. It's not going to end today. It's not going to end tomorrow. We don't want it to end tomorrow. We want it to be ongoing and make it better. And we sort of break it down into 4 parts. We have screening and prevention. We have treatment of early cancer. We have advanced cancer diagnosis and treatments. And we have the future of cancer treatment. And we have all those things going on right here in Sarasota. And let me just give you a capsule of what we're doing. So if we break down screening, I'm just going to hit these 3 topics. I'm going to hit cervical cancer, breast cancer, and ovarian cancer. I'm going to start by saying cervical cancer, if you remember, it was the #1 cancer worldwide in 1945. The #1 cancer around the world. And then in 1945, Pap smears were developed. And what the Pap smear does, and if you look at the screen, I don't have a pointer that can show you, but on the left-hand side of your screen, you see the uterus and the cervix. And what you do is you swab the cells and you put them on a slide, which is the right-hand side, and you can predict a cancer 5 to 10 years before it becomes a cancer. It's been the role model for all cancers, is cervical cancer. So it's changed. That's why we don't see as many cervical cancers if you get a Pap smear. We've taken that a step further. All cancer research is looking for vaccines. We're looking for a cancer vaccine to prevent cancer. Cervical cancer came to the forefront. We know cervical cancer is linked to the HPV virus. And we know that 80% of women and men are exposed to the HPV virus in their lifetime. Well, what if we could prevent cancer by preventing the HPV virus? And that's what the vaccines do. When I was at Moffitt, probably about 12 years ago, one of our research fellows, and I stuck him there a whole year trying to develop a cancer vaccine for cervical cancer with mice in a mouse model, and it failed miserably. In fact, the guy almost didn't pass his thesis because he didn't have a project. And then later on, I realized it was going to be a big company that would be able to develop it. And sure enough, that's what happened. There's 2 of them now. Merck and GlaxoSmithKline have brought to us vaccines. And this should eradicate cervical cancer if kids are vaccinated before they're exposed to HPV virus. And so my take-home message is make sure kids are vaccinated, encourage parents, because we could eradicate that, just like polio. Cervical cancer could be eradicated. This is the prototype for all vaccines. Breast cancer, I'm not going to go into a lot of detail with breast because I know we do the Key to the Cure, the Sachs fundraiser each year, and we talk a lot about that. But I will say in one slide, the focus on breast cancer is density. Is your breast dense? How do you see through a dense breast? And the newest thing on the market is a 3D mammography, the tomosynthesis, as we call it. And that's the newest thing on the market, and its purpose is to evaluate dense breasts. And I'm just going to stop at that just for the interest of time. I'll answer questions later. Ovarian cancer is our biggest killer for GYN cancers because we can't find it early. If we look at ovarian cancer, how do we find a screening test for something where the signs and symptoms are bloating? Now, everybody that leaves here today is going to have some type of bloating from this meal, and it was a delicious meal. and you're going to have to differentiate, do I have ovarian cancer or not? And 99% of the time, the answer is going to be no, but we want to find that one person. And that's the problem with ovarian cancer. So we're actually doing a study. We're actually doing two things with ovarian cancer. This is one of my former students. He was a resident and a fellow with me in Tampa, and he's now the director at the University of South Alabama in Mobile. And he said, why don't we get together? He goes, we cut out tons of tumor all the time. Why don't we look at the proteins? And if we do this right, the proteins that we see in the belly travel down the fallopian tubes, down the uterus to the cervix, and maybe we can do a pap smear and find those proteins. Not look for the standard cervix cancer. Maybe we can look for proteins that are being shed early. And so that's what we're doing. We're actually, the Sarasota is #2 in the country of the 14 sites around the country doing this study. University of South Alabama is #1. So we're doing that. It's hot, it's top, and I don't know where it's going to go, but it's a hot topic. We're also finding that genetics is a big deal. We have the ENGAGE study for cancer genetics. Everybody with ovarian cancer now, we have a study, and they're offered gene testing for BRCA1 and BRCA2 gene testing. And the warning signs, and it's in your hand, I'll just read them to you briefly. If you're at risk for breast or ovarian cancer, it's breast cancer before age 45, patient with breast cancer before age 45, ovarian cancer at any age, anybody with male breast cancers are at risk for genetics, bilateral breast cancers, breast and ovarian cancers, anybody that has a known mutation, a BRCA mutation, people of Ashkenazi Jewish descent, and people with triple negative breast cancers. These people should all seek a genetic counselor and see if you're at risk. And you all know the media coverage with Angelina Jolie. As you know, she was an actress that had a prophylactic surgery for her breasts and her ovaries. What most people think, though, is it's because of breast cancer. Her mother developed ovarian cancer at age 49. Her grandmother developed ovarian cancer, and her great-grandmother developed ovarian cancer with the nonspecific bloating. And she had other relatives with breast cancer as well. She had the BRCA1 gene abnormality. And with her testing, by her coming out in the open, she says, I'm going to do it to help my family. I want to see my grandkids grow up. She knew she was at risk. With that, since her testing, before testing, and you can see in 2012, there were 1,900 genetic tests done. That year, since May 2013, when she announced her prophylactic surgery, there were more than 4,000 tests done. We have a genetic programs here in Sarasota. In the last 3 years, we've screened patients and families of 1,000 patients in the last 3 years. And so they know more about their cancer risk and more about their family risk to prevent ovarian cancer. And it's a wonderful thing. So know your risk, and I encourage you, if there's any question, if you hit those red flags, talk to the genetic counselor. I'm going to move off screening, and I'm going to talk about treatment for early disease. I'm just going to say what we have going on. You already heard the robotic technology. 6 years ago, the Healthcare Foundation bought the first robot, and we knew we were going places with this technology, and we continue to use it in all our cancers to improve outcomes. What about maintenance therapy, though? This is kind of a hot topic. How do we, if you cure cancer, or you think you cure cancer, you make it go away, how do you prevent it from coming back? And that's what maintenance is all about. We have 3 different projects going on trying to prevent cancers from coming back, and I'm going to specifically talk a little bit about cancer vaccines. I'm going to talk a little bit about a new drug called a PARP inhibitor, which incorporates into the DNA of the cell to prevent it, and I'm going to talk about the immune system. What can we do with diet and exercise? We have 3 studies that we've been doing ongoing in all 3 of those fields. The vaccine study, let me just back up 1 second. I want to talk about the ovarian cancer vaccine. I go all around the world and I try to find things. We want to find drugs that are in the future. So I was approached by a company in Australia to say, would you pilot an ovarian cancer vaccine for us? And I looked at it, and of course I asked Tamil, my research specialist, to say, is this a practical thing? Because it hasn't been done before. And she said, I think we can do it. So we did. We set out, we took clumps of tumor from patients with ovarian cancer. We sent the tissue to Germany. We sent the labs and blood testing of the patient in Germany. The patients that were interested in the study came back Before they started chemotherapy, they healed from their surgery. We put 2 IVs in, took their blood out of one side, at one arm, separated the white cells and the red cells, gave them their red cells back with the Southwest Florida Blood Bank, sent the tissue, the white cells, to California, where they made a tailored vaccine for that cancer. Patients got their chemotherapy, and then they got the vaccine back. And we actually did the first 10 studies in the world with the ovarian cancer vaccine. We actually did the pioneer work. What they wanted us to do was develop the technique, and we did it well. And now that project's ongoing in Germany, and we'll hear more about it. PARP inhibitors are new. PARP inhibitors are a way you can, the patients with ovarian cancer that are free, there's new drugs now, there's several of them that can actually come in pill form and IV form that incorporate into the DNA of patients to try to prevent their cancers from regrowing again. We actually have a big ongoing national study right now with the GOG in patients with ovarian cancer that are cured of their cancer, and they get the PARP inhibitor to try to prevent it from coming back. We basically have a study on diet and exercise. People always say, can I be healthier? Will my cancer come back? Or can I prevent it? Everybody wants to know. Well, we actually have an ongoing study with the University of Arizona, cooperative and going on around the country, where at the end of cancer treatment, they actually get randomized to standard living versus having a personal trainer that basically tells them how many steps and what kind of diet to eat, and they keep a diary to see if we can change that, see if we can impact that. So that's ongoing. I'm going to move into advanced disease and sort of end this in telling you about the future. One of the problems with advanced disease is we're always looking for new drugs. We've had 34 studies in the last 6 years, and this slide shows you the different cancer types that we've been doing, looking at new drugs that aren't necessarily available, trying to improve advanced cancer. Where do we stand? What's the future? Well, now there's 40 new targeted drugs, these new what we call small molecule drugs that we're trying to incorporate. They can't kill the cancer by themselves, but they can incorporate into the cell and prevent the pathway of the cancer growth. And the question is, how do we incorporate these 40 drugs into our treatment? And that's where the future is going to be in cancer treatment. There's these pathways. You can see on your slide, there's all these pathways. There's things called an anti-angiogenesis. You guys have heard of Avastin. There's things called AKT pathways. There's things called tyrosine kinase or mTOR pathways. These are all pathways in the cells, and now we have a drug that can target that pathway. So in this slide, I know you can't see it well around the room, but if you picture that white thing being a big cell, a big cancer cell or a big normal cell, and basically that outer line is the outer wall of the cell, and each of those little lines in between with the colored dots are pathways. We want to be able to basically find out what that cancer is for that patient and give them the specific drug to shut off that pathway. And that's what we're doing. That's what these targeted personalized medicine pathways are. So the future is basically all going to be, how do we incorporate this data? How do we link up with cancer centers around the country, around the world? And how do we take the patient's tumor and do a biobank testing and link the two together? Link that drug with that patient and use all the resources from all the cancer centers around the world. And that's really the future of medicine. That's personalized medicine. And that's what our focus is over the next several years, is how do we incorporate and make all that happen. So that's what you're going to see coming out. We're actively involved in it. People always say, what can I do to help? And we don't want you to have a cancer to help. We want you to contribute. What I'm hoping people will do is when they go home and take their slides, they'll pick one of those topics. Pick screening, pick early disease, pick maintenance, pick the future new drugs. And if you can contribute in any way, talk to Alex, because we certainly look forward. I invite everyone or anyone to pick a topic. You can make an impact on it if it's genetics. Right now, biobanking, tissue biobanking is huge for us right now. We're trying to set up a tissue bank. I encourage, if anyone has any interest, talk to Alex. We could actually, we could pioneer this project around the world. Thank you very much.
Are you seeing the theme here? It's a team approach. Top-notch doctors make it possible to have the latest in technology and the latest research. Our last speaker is our most colorful speaker, and pink. And she brings the cancer journey to a close. She almost, well, she does. You have the best job of the three doctors because she sees patients who are survivors. They're on the last chapter of their cancer journey. And I'm sure most of you have been touched by cancer, either yourself or your family or friend in this room, and you know that when a woman in particular goes through breast cancer, cervical cancer, or has any sort of surgery that impacts your physical appearance, it really wreaks havoc on your emotional state. And there are a lot of studies that demonstrate that stress and poor attitude can jeopardize long-term recovery. And that's where Dr. Schulman comes in. She is a board-certified plastic surgeon, and she is the section head of plastic surgery at Sarasota Memorial Hospital. I could go on about her credentials, but she's best known not only for her pink hair and her pink cowboy boots, because she gets it. She understands that her mission and her purpose in life is not just to reconstruct so that a cancer patient can survive, but she wants them to thrive. And her energy and spirit are contagious. You will know that you have no doubt that she does it successfully. Dr. Schulman, Elisa Schulman.
Thank you. I love it. Thank you. All right. Well, again, it's kind of odd having to round up such an amazing set of presentations here. And let everyone take a nice deep breath. I'm just going to warn everyone, we're going to look at lots of pictures of breasts today. That's what I do. And the first few are the only ones I'm going to call scary because, you know, as we tell our kids, I said, you're learning history because we want to improve on it. And so we have to learn where we've come from to know where we're going. And so this is a picture of a classic radical mastectomy, which even in my early days of general surgery, you still saw patients that went through this, and it's nothing but devastating. And this was certainly before our days of reconstruction. So then you get on to the 90s, and we start doing where you can actually leave some of the skin. Still somewhat devastating. Some of these were modified radical, some were skin sparing. Again, still devastating. Then we get into more reconstruction, and I thought they looked pretty good. This is one of my reconstructions within the past 6 years. And they were pretty good, but you can still see the scars in the middle, and it still reminds the patient of what they've gone through. And so, you know, the big thing is I wasn't unhappy with the old reconstructions, but they weren't perfect. So the shape isn't as natural as their old shape. The scars right in the middle, the nipple's not their nipple anymore. And so, you know, what can we do about this? And the real question is, you know, can you keep the envelope? Can you keep the nipple? Can you hide that scar? And right now, I can finally say yes to all of those. That's a big deal. And that is a form of a nipple-sparing mastectomy. Oh, we're going to come back. And the reason we have nipple-sparing mastectomy is because sort of a perfect storm was happening in the 1990s where a lot of things were going on. And medical care was changing, and we did touch on it earlier. We're going to go back to Angelina as always. But the internet, a big deal. Internet bigger in the 1990s and the 2000s because now people can exchange information at the press of a button, and so we have immediate information around the world. This wasn't just in one place, and for the most part, when I went into researching this a couple of years ago, you can't find the birthplace of a nipple-sparing mastectomy. No one can claim the first. They've been going on for actually, you know, more than 20 years, but not necessarily for cancer and not necessarily something we had pinpointed. So we have the internet, we have support groups. Women are talking, women are sharing. Someone's going to say, so-and-so was able to save her nipple. Can I save my nipple if I get breast cancer? So again, a lot more communication. And, you know, and the genetic testing that Dr. Fiorica mentioned, that's a big deal. We did not have that the BRCA testing until the 1990s, that it was widespread. And so now women who are at high risk can see if their children can see if they're high risk, and they can take their medical care into their own hands and prevent a cancer. And again, this is where, again, patient-driven, that's a huge force in medical care these days. And really, when we were in med school, it was just starting to happen. No longer did the doctor just tell you what to do, and you listen to them. Now, my patients ask questions, and I expect them to, and I want them to. They come in here with internet sites and pictures and questions, lists of questions. And that's perfect. That's part of the team. I want you to be part of the team. I want you prepared, and it's a little harder for some of our senior members to accept that they might be questioned, but that's how it is. And then again, the Angelina Jolie effect. That was not just women taking breast cancer in their own hands, but actually preventing it. And we keep going back to her because she's very visible, and she made it easier for women to ask, can I prevent this? And we have to, accept the fact that publicity and social media plays a big part in this. All right, and then, the other big question is everyone a candidate? So that's what everyone wants to know. Kind of tough to answer in a few seconds, but really, we're looking for smaller cancers, single-site cancers, non-radiation breasts. There has to be farther away from the nipple, and we're constantly pushing the envelope on that. But again, it's still kind of slow into coming because you'd hate to think you left a cancer behind. But that's the first step. When you work with a team, we work with a team here. Myself, Dr. Russell Novak, we've become a real hand-in-hand team here. Dr. Fiorika's coming on board with the nipple-sparing mastectomy. We're bringing more and more surgeons to the forefront for nipple-sparing, and I applaud them because it is a big step when everything they learned before this was to take the nipple away. So it's a big deal. And again, it's a team effort. I'm there from the very beginning of the first cut because I'm actually the one protecting the nipple because I'm taking care of it for the next year or two. So it's very important that we do this all together. We communicate. So if you are an actual cancer candidate for nipple sparing, that's great. But then the next step is, is it a breast we want to save as far as the whole shape? And I'd like to say everyone deserves a beautiful breast. And if you come to me and you say you've always wanted a reduction or a lift, then that might be not your best option to do a nipple-sparing mastectomy, because when we save your breast shape for a nipple-sparing mastectomy, we save every last bit of it, whether you like it or not. So I want to make sure it's a breast that you want to save every last shape. So I may be the one person that says, I want it to look pretty, and if you really want it to look pretty, we might have to take the nipple in order to lift it, which is kind of a big deal, but we can reconstruct another nipple. And, the goal is for a beautiful breast, so not everyone's a candidate, and sometimes I do have to give the bad news and say, well, that breast is just a little too droopy to keep like that. But on the other hand, we're going to have nice, perky breasts, and that's always a good thing. So we go over that over and over again. I try to make sure it's a good thing. It's a good thing. And so these are some examples of my nipple-sparing mastectomy. So someone would decide to go a little bit larger. Some women, my goal is that they look exactly the same. So just so you know, the left side is pre-mastectomy, the right side is post-mastectomy. These look like their breast. That's the goal. That scar is under the breast fold. Nobody gets to see it. All right, and again, we save the breast, and this is where I say if they're a little droopy, we save that. So you have to be able to accept that that's what your breasts are going to look like. But they look nice. I mean, they look natural. That's the goal. Okay, so other innovations, not just this one. The implants have come a long way. I know everyone still hears implants and they shudder. The old silicone implants, oh, they're bad. The new silicone implants are completely different. I can't really fault our forefathers. I trained in Houston, and that's where they developed them. They didn't know that the liquid silicone was going to leach through and cause problems. It doesn't cause cancer, but it can cause the breast to get really hard, and so it's very hard to detect cancer. So once they figured out what the problem was, it was just the wrong silicone molecule. Now we have solid gummy bear silicone molecules that work very nicely. We have lots of shapes and sizes, and I would be a fool to say they're perfect. I don't know if they're perfect. They've been great for the past 12 years that we've had them, but I think compared to anything else we've had, they've done really, really well, and I think it's still gold standard for reconstruction. The other thing is, we got here, something that is probably the nearest and dearest to my heart is something called fat grafting. Before all med school and everything, I was an art school major, and I went for sculpture. I like to sculpt. That's what I do. Fat grafting has let me sculpt people, both for cosmetic reasons and reconstruction reasons. And to me, fat's the best thing in the whole world to sculpt with. And in a world where everyone wants to get rid of their fat, I'm telling my patients, no, don't get rid of your fat. I need it later. So, it's a natural, it feels more natural. now we have a little bit of cooler weather. Some patients will actually tell me that, their breasts feel cool. Their breasts don't feel as natural. And when I put a layer of fat over them, they feel warmer. It's amazing. But it feels more natural. I can get a little bit, there's often a little bit of a ledge right at the edge of that implant, and I can kind of soften that up with some fat. And again, it's a win-win. You get to lose some fat from one place, and I put it in another place. I do it for cosmetic reasons. I do it mostly for reconstructive reasons. This is a good chance to say that reconstructive surgery makes me a better cosmetic surgeon, and cosmetic surgery makes me a better reconstructive surgeon. They fit hand in hand, and I get to do both. Lumpectomy divots. We haven't really talked about lumpectomies. It's something that, happened over 1980s, 1990s, a great option for many women, but sometimes it leaves them with a divot after radiation. And most of the time people would live with that, but we don't have to, and this is Florida. The bar's raised really high for clothing here. You can't hide under sweaters. So, most of the time. And so fat grafting lets me gradually tease out those divots with your own tissue. And just a little plus, fat grafting, fat has something called mature stem cells, which help your body get a little younger, a little healthier, a little softer. It's a good thing. And there's, pretty much an infinite supply of fat almost everywhere. And again, fat really makes a big difference. But again, we're going to say it's not necessarily perfect. I'll get that in there. There we go. Again, it's not perfect. It does require more surgery, although I would call it about as minimally invasive as you can get. We're talking, 4mm incisions, no stitches, no drains, just a little bit of bruising. It really is a very nice step, considering all the other surgeries they've gone through. And you will lose a little bit of that fat, but when it's really treated carefully, and I guess I'm very glad that I've been able to learn a very fine technique, and so maybe 10% of that fat's lost. It can occasionally leave tiny little nodules, and we always follow those up. I may have to biopsy them, I may have to evaluate them, but it's still pretty rare. And now that, they've been doing fat grafting actually for, many, many, many years. It's just that it wasn't until the past 10 years that they realized you actually have to treat fat like a living tissue. It's not just a filler you can stick in anywhere. It actually is living tissue, so it needs a blood supply. And so you have to put tiny little droplets of fat amongst the tissue to get a good blood supply. And that's kind of a little bit of an illustration. It's little droplets in the middle of lots of different healthy tissue. And so that's been the big advantage of not putting a lot of fat in one area, but lots of little droplets. I actually use a very kind of a delicate facial injection technique for my breasts. And really, I don't lose fat. I'm really been very happy with that. And you can really tell when you have a very slender patient that can't afford a single drop that you've moved on them, and they keep it all. So it's really nice. Again, it's a living tissue. We've got harvesting the fat. We can go over a little easy. It's just like it's liposuction. There's nothing different about that. I suction the fat out. You're asleep for it. I make sure I take the fat from where you can lose it. I would never want to go from one divot to another. I really want to make sure that it's a fat that you can get rid of. And almost every woman has resistant fat, belly, hip, something. And that's the fat I want. That's the fat that's going to stay no matter what. So that's where I want it, It's a little bit of bruising, a little discomfort. But kill me. So we go on to that. That's actually a filter. It's a wonderful filter because something around that fat is fluid, some blood. We don't want that. So there's little closed system filters that get rid of that. That makes perfect fat for later. And then as far as injection, I just have to be very careful. I use very blunt needles. I have to go right around either an implant or into scar tissue. Again, very delicate technique. That's just a little kind of drawing I did to show how that goes. Even a millimeter of fat around a breast implant makes a difference. And so these are some pictures. Actually, they're pictures of the patients you just saw earlier. And I have them position themselves to show the divots and to show the thinness. And then that's after the fat grafting. So the final pictures you've been seeing have been after fat grafting. Pretty much 90% of my patients are very excited for the fat grafting because that's that little carrot at the end of the line there that says, I get some liposuction and some fuller breasts. And again, it's very nice. Okay. And again, I can use it to fill divots for lumpectomies. Does very nicely. I usually wait about a year after the radiation so that the settling's gone in. Same idea. These are pretty big divots. They take a couple of sessions. That little divot is not waiting to be filled up with fat. So multiple sessions of teasing out that scar, and I have this little tiny little pickle fork that teases the scar out, and I drop fat in. And in this patient, she didn't mind being a little bit bigger, so we filled in divot gradually and gave her fuller breast. That's all her own fat. Again, all of that helps. Some are pretty big divots from lumpectomies. All right, so, the main thing is the last new talk about, things about breast cancer treatment aren't necessarily new techniques. They're really just an acceptance of things we've had. One of them is three-dimensional tattooing. I mean, I went to art school. I actually studied with a tattoo artist to do my own tattoos. But I'll be honest, they're okay. They're not perfect. But then finally, within the past couple of years, regular, traditionally trained tattoo artists have come to the forefront to show us that they really do have the skill level to do what we need them to do. And so now that the public accepts it, now we can make a better bid for real tattoo artists doing this work. This particular gentleman, Vinnie Myers, is the one who travels all over the country for 3D tattooing. He just sort of opened the door for everybody else. This is some of his work. And I mean, I'm not, you may have, actually one of the first pictures you saw was mine, so these are all his, and they're really very natural. I am now currently working with some local tattoo artists and setting up a little corner in their studio to do my patients. And, I have to accept skill for when it is and art skill for when it is, and these are some mock-ups of some of the drawings we're working on. It's very nice, and these particular gentlemen have had a lot of close contact with family and members who've had breast cancer, so they want to give back to the community, and I think that's going to be a great relationship with us. And just to finally close everything up, my patients want to get back to being whole and well and back to where they were before. That's what we do. One of the first things I ask them is, so what are your favorite things to do? Can we get you back to those? I don't want them afraid to get back to their activities. We spend a lot of time with them. It's usually about a year or two with me with a reconstruction, so we end up being friends and family. Anyone knows my office. My mom's my office manager. We're all very close. And we have a lot of friends who are our patients, actually. And we get them back. We get them back on their paddleboard, playing tennis, back swimming, scuba diving, whatever they want to do. And that really makes a difference. We have kind of a closeness. When you come to the office, you will see that, we have a different kind of medical setting. It's a very kind of a coastal feeling. You got to love the water to come here. And it's just very nice. But that's the general direction we're going in women's health care. We want you to feel it's personal. We want to understand we're getting back to wellness. We want to get back to what you love to do. And it's, again, I compare men's health care with, a race car pit stop. Women's health care, a little more spa-like, and we're getting back to that. That's a big deal. These are examples. This is actually the Lotus Center. That's where Angelina Jolie went. This other center in Philadelphia, that's where I went, and we actually learned to train for the nipple sparing mastectomy. It's a different feeling. You can see it's much more cozy, wholeness, that sort of thing. We're going in that direction here. I know we are. We've got all the pieces setting up. I know, Alex mentioned it. We will be a nice women's cancer center, a full cancer center as well. But we're getting there. So, and again, support is all we need. Thank you.
If you have questions at your table, raise your hand and somebody from the foundation can collect them. Rachel's going around. Keep your hand up. I see Nikki going around. I want to before we begin the questions, I want to again thank our panel. And I hope you understand that our goal was to really educate you because you need to know these facts to stay proactive in your own health care and to understand the needs that our hospital has and why we're always out there asking for your support. So Deb, do you want to start off with the first question?
I have a question from the audience. What should we do about getting a, quote, second opinion following a cancer diagnosis?
The question is, people are diagnosed with cancer and they want to know, is this the right treatment? So they'll come in to see you, and probably the most important thing is that you realize you're getting the state-of-the-art treatment. You don't want to take a second line treatment just because you're in a certain office. And so what I usually do is I tell people, do your homework. I said, this is what I recommend. I'll make the referral for you. If you have a family member in New York, if you have a family member in Texas, I'll set it up for you because I'm comfortable knowing that they're going to come back for treatment. And I think that's really what it depends on, the experience of the person that's treating you. Make sure you have someone that has experience because they will come, once they get their second opinions, they'll come back. It's always much more convenient to have your treatment locally. You have family support locally. You just want to make sure you're getting the best drugs, you're getting the newest drugs, you're getting the best surgery, you're getting the best quality, and I am convinced you will get it, and that's why I always recommend if someone wants it, I'll even arrange it for them wherever they want to go, wherever they have family.
I'm going to direct this question to Dr. Meredith because I actually think you already answered it. And the question was written by a doctor in our audience, and it reads, I am a primary care concierge doctor. Can you help me to convince patients that our outcomes are at least equivalent to Moffitt so that they don't delay care by running outside of Sarasota? And quite frankly, I thought the whole luncheon answered that question, but please.
Wow. The easiest way to answer that question is to echo what Dr. Fiorica said. And I'm usually on the other end of things. I usually have patients come to me from a second opinion. I'll just tell you this week in clinic, I had 2 patients actually come to me as a second opinion from Moffitt, and actually one of them was a guy I'd operated on in 2011. So the easiest way to convince patients is to echo what the message that we've said here in town. First of all, I'll tell you, you're not going to get anyone who's past their learning curve, and I can go on record and say this, at some of these other cancer centers, you're not going to get people specifically for robotic and specifically for esophageal and pancreas in the state of Florida. You're not going to get anyone that's outside their learning curve. And again, I want to echo that. They're not outside the learning curve. So what does that mean? That means that it's going to take longer to do the operation, and their outcomes or their postoperative morbidity is going to be higher. You look across the board. I can stand up here and say this because I know the data. I've seen the data that was published, and it is what it is. There's people that have done enough of the operations that their outcomes are lower. The easiest way to convince a patient is, like Dr. Fiorica said, you have to do your homework. First of all, I'm a data-driven person, and I know we didn't have a lot of time to show a lot of the publications, but when patients come in to see me in clinic, the first thing that I'll do is I'll tell them, this is my name, these are the last 5 papers that I've published, Google them, you can look yourself at the outcomes. So you know that it has been reviewed in a peer-reviewed fashion, that this is our data, these are our outcomes. That's the easiest way to convince patient. And it's like Dr. Fiorica said, we can get patients to come back here. I was on the other end this week. I had seen a patient a year ago for pancreatic cancer, needed chemotherapy. She is borderline resectable. She had Pittsburgh insurance. A very, very good friend of mine up in Pittsburgh, Herb Zay, who's one of the pioneers for robotic pancreatic surgery. Went up to Pittsburgh for a second opinion, got their chemo up there, got time for surgery, and then she said, well, I want to go see Dr. Meredith. Or actually, she said, I want to go back to Florida. And you don't know, I got to embellish a little bit. Dr. Zay's very happy with himself, and he puffs his chest out and goes, well, you won't get me. And then the patient goes, well, I'm going to go see Dr. Meredith. And he goes, oh, you know Ken? Well, you're perfectly fine. You can have your operation in Sarasota. So, part of it is building a team that we have here, and part of it is the continued publication of your outcomes. That's the easiest way to convince patients, but you also have to be on board with the team approach, and to me, that's the easiest way to do it.
Dr. Fiorica, I have like 16 questions here, all related to what the heck do we do about mammograms? So they tell us, yes, get a mammogram, don't get a mammogram, get a 3D mammogram. We won't pay for a 3D mammogram. Get an ultrasound. What do we do?
So the mammogram issue, unfortunately, is going to get more confusing over the next 6 months. There's the recommendation guidelines are changing once again, and not necessarily for a good reason. There's no real consensus again. So I warn people, be careful. In fact, I was just asked to write a fairly big summary chapter 6 months from now to review the literature over the next 6 months in one of the big breast cancer journals. And so I'm really focused on the mammogram guidelines. But I will say, be careful right now, because the American Cancer Society just changed their guidelines last October. The U.S. Preventive Task Force just changed their guidelines 3 days ago, and there's going to be a big journal article published next month in February regarding the guideline changes. My recommendations right now is what I always tell people. At the present time, don't be reactive. Don't stop getting mammograms. The guidelines are spreading them out. Each of the guidelines are a little different too. The American Cancer Society is sort of saying, you know, between ages 40 and 45, sort of know your breast and know your risk factors. Then they're sort of saying screen, you know, each year till 55. Then they're sort of saying going every other year from 55 onward. The U.S. Preventive Task Force is sort of cutting off at age 74, but people live longer than 74. And so right now, my recommendations right now is do not change what your current guidelines. If you're getting them every year, continue to give them every year. Let the dust settle for the next 6 months because there's going to be a lot of controversy in the media. I will say, breast, the biggest thing now is the standard film screen mammogram is great. The name to fame for the 3D mammograms or the tomosynthesis is if you have dense breasts. So now the reports are supposed to tell you, the new reports are supposed to say your breast density. They make it A, B, C, and D. And C and D are the denser breasts. If you have a C and D, well then that's not breast size, that's breast density on the report, okay? And so if you have a dense breast, the 3D mammogram is probably better. For everybody else, they're identical. So that's why I say know your breast, and that's really the only change I recommend at this point. Don't make any changes on intervals.
Thank you. The number of questions indicates your thirst for knowledge, but our time is running short, so we've got time for just one more question, and I want to address this to Dr. Schulman. Everyone's very impressed with what you can do. Does insurance cover the cost of reconstructive breast surgery? And what about robotic versus traditional surgery? Do you do it the old-fashioned way, or?
For the most part, robotics doesn't quite carry into breast and breast cancer and plastic surgery for the most part, because everything we do requires that I actually move skin, and I'm just able to hide the scars very well. So as much as we're always keeping our eyes open for robotic, for certain moving of certain muscles for reconstruction. For the most part, we're not robotic. We're pretty old-fashioned handwork. As far as insurance, don't get me started on all of the insurance ordeals, but as of 1998, Women's Health Care Act, insurance covers breast reconstruction. Now, does that make it easy for breast cancer reconstruction surgeons to do that? No. They don't say when they pay you, how much they pay you, and if you'd ever look around Sarasota, there's a ton of plastic surgeons. Very few of us are doing reconstruction, and it's certainly not because, you know, it pays well, but that's not why we do it. But it does make it hard to make a living as a plastic surgeon. That's why I say I'm half cosmetic, I'm half reconstruction. They work hand in hand, but you are entitled to a reconstructed breast for insurance, and that includes the other side, and that includes multiple steps, and I fight to the very end to get that covered, so I never question that. There have been some loopholes with Medicaid and things, and that's where we work with grants. That's where we work with the foundation and fundraising so that everyone can have a reconstruction. Some of the other areas that get a little gray is, you know, the aging breast on the other side, 20 years after a reconstruction. It's kind of hard to argue with natural aging, but the actual breast cancer breast, I can always fix it, and I will always push it through insurance. That should not be a problem.
And I wanted to leave you with one last thought. We've been around for 40 years of asking for support, garnering support, and providing support to this amazing institution called Sarasota Memorial Healthcare Foundation and to the healthcare system. So please, as you think about your futures and you think about the fact that likely you will end up there or you know somebody that will end up there, please think about your support. We've raised, well over $100 million. We've given $62 million away, and we need to give another $62 million away, so please be thinking of us. Thank you and have a wonderful day.